Okay, so this is the first of a series of, I think, about three lectures here on the elimination lecture. And we'll start with bowel obstruction. And bowel obstruction can be partial or complete, and it can be caused by mechanical causes or non-mechanical causes. Mechanical causes are things that block the passage through the intestines. Things like tumors, stones, fecal impactions, adhesions, hernias, volvulus, intussusception, stuff like this. These are things that just block the flow. And non-mechanical causes, this is where the nerves that innervate the bowel aren't working, and so therefore there are no peristaltic waves in the intestine. Okay, so the signs and symptoms of intestinal obstruction would be abdominal pain, cramping, vomiting. Now the bowel sounds, initially they're hyperactive because the bowel is trying to push the stuff through, the contents through the intestines, but then they become hypoactive as the effort doesn't work, and then they become absent. And this is why you remember back to our physical assessment where we have you listen for 5 full minutes on each quadrant, because if they are absent, then often this is the reason why. And then you ask them, when was your last bowel movement? And they'll say that they haven't had a stool passage for a while. The abdomen will also be distended. They'll be dehydrated, and often they're going to be in hypovolemic shock. And the treatment for bowel obstruction, it's usually diagnosed by a CAT scan, or sometimes they'll do a exploratory laparotomy. They'll put an NG tube in to decompress the bowel. The person will be NPO. They'll replace all the fluid and electrolytes because the person will be in shock and dehydrated. And they'll usually do surgery. They'll go in and find the area where the bowel is obstructed and remove that obstruction. And after surgery, often it's painful, so they'll give them pain medications like narcotics. Now, this is key to understanding bowel obstruction, the pathophysiology. And if you look down here at the bottom of the little diagram on the right, you'll see that there's some kind of obstruction, and you can see proximally to that the bowel becomes distended. And you can see that fluids, gas, poop, all kinds of stuff get trapped in there, and the abdomen gets really distended. Because of this distension, it's going to be painful. They'll have an increased abdominal girth, and that area down there where it's obstructed, you'll see a impaired blood supply there, and necrosis will usually set in. The bowel a lot of times will perforate, and it'll lead to an inflammatory reaction, and often the person will go into shock because of this disorder. Now, the bowel obstruction patient, usually they're really sick at this point, and often they have to be in ICU because of the shock. And often we're going to give them pressors like epinephrine, dopamine, dobutamine, just to maintain a normal blood pressure because this person's pretty sick. Okay, another common disorder that we'll see, often this one is seen after surgery. What happens is the person hasn't voided for a while and their bladder fills up, and they have the inability to empty their bladder. And you can see in the little diagram up there that the bladder is distended, the person can't urinate. Like I said, it happens very commonly postoperatively, but it could also be caused by other disorders. If you look at the third bullet item there, you can see that the normal residual urine should be less than 50 milliliters in an adult and less than 100 milliliters in the older adult. And this is done by doing a post-void residual by a bladder scanner. And so it usually should be less than 50 or less than 100 in the geriatric patient. Strategies to help the person to empty their bladder: make sure that you provide privacy. Often it's easier to urinate if they're sitting instead of laying flat in the bed. Try to position them to a position that's comfortable to void. If you can, help them get up to the bathroom. Sometimes a warm compress will help. Sometimes giving fluids will help them to urinate. It's very common that we would run water in the room, like turning on the shower or the faucet. A lot of times when you hear running water, it helps you to urinate. It makes you feel like you got to go right now. Sometimes we'd even put their hands in water or their feet in water, and that would also help initiate that. If the patient still can't go, then it's very common to catheterize them with a straight cath if they haven't voided for 8 hours. Okay, now paralytic ileus, this is another common occurrence after surgery. What happens is we put the person to sleep. Their GI tract is put to sleep after surgery, and it takes a while for it to wake up. And so in paralytic ileus, we have a paralysis of the intestinal muscles where there's no bowel sounds, no peristaltic movement following surgery. Now, it's very key. We never give them anything, food or fluid, by mouth until after they are passing gas or have bowel sounds. So we don't want to give them something before this time because they'll vomit it up, but we don't want the person to have aspiration pneumonia. What we do is we do something that's called progression of the diet. And often after surgery, once we hear that they have bowel sounds, they may tell us that they're passing gas. Then we'll usually start with ice chips, and that's just crushed ice. And we give them a little spoon at a time and see that they tolerate it well. And if they tolerate it well, then we usually progress their diet to clear liquids. And so we may start them with water or apple juice or something that's pretty mild. And then if they handle that well, then we go on to full liquids. And if they handle that well, then we go on to solid foods. So that's the progression of the diet after surgery. Now, critical thinking down there, the point says, should we give a post-op patient acidic food such as orange juice or spaghetti? And the obvious answer there is no, often because the stomach is empty, and if we give them something that's highly acidic, they're going to vomit it right back up. And so we want to usually start with more mild foods after surgery, and then we'll progress to stuff like spaghetti and orange juice later. Okay, so the next little section here, we're going to talk about urinary tract infections. And urinary tract infection is very common. It's more common in women. I think it's about 8 times more common in women, and the most common causative organism is E. coli. I think about 80% of all the urinary tract infections are caused by E. coli. The most common place in the urinary tract to get infected is the bladder, and they call that cystitis. But the urinary tract infection can be anywhere in the urethra, the bladder, the ureters, all the way up to the kidneys. And you guys know that the urinary tract is normally sterile, so there's no bacteria there. It's usually the flushing motion of the urine through the tract that keeps the bacteria out. The pathophysiology states that bacteria ascend the urinary tract. It leads to an inflammatory reaction and then infection. And like I mentioned before, it's more common in women, and you guys know that this is because the shorter urethra, and E. coli is the most common bug that causes this. And it's very common if someone has a urinary catheter for them to get urinary tract infections, and they call this a COTI. It's a urinary tract infection that's caused by someone having a urine catheter. Okay, now the signs and symptoms of UTI would be dysuria or painful urination, frequency, urgency, cloudy urine, hematuria, fever, and flank pain. Frequency has to do with the person has to pee all the time. So maybe they peed 15 minutes ago. Boy, they got to go again right now. And it's 10 minutes later and I got to go again. Urgency means that, they got to go and they don't have time to sit around and wait. They feel like they have to go right now. Cloudy urine, that's pretty obvious. Often you're going to see stuff floating in the urine, and hematuria, that's the blood. Now treatment, we're usually going to do a culture and sensitivity before we start the antibiotics. The culture will show what kind of microbe is growing in the urinary tract, and the sensitivity is going to show us if that microbe is sensitive or resistant to the different antibiotics. And then once we do a culture and sensitivity, then we're going to start them on antibiotics. And sometimes we'll give them analgesics because of the pain. And something that also helps is acidifying their urine. So giving them something like cranberry juice, vitamin C, it helps kill bacteria in the urinary tract. We also want to increase their fluid intake, usually 2 to 4 liters per day, and this helps flush the bacteria out. And a couple of things that we want to teach our patients here. One is that we want them to take the full course of antibiotics. It's very, very common for people when they have a urinary tract infection that they say, oh, after 2 days I started feeling good, so I stopped taking the antibiotic. But you want to caution against this because the bug can grow back and become resistant to the different antibiotics, and we don't want that to happen. So tell them to take the full course of antibiotics. Some of the medications, for example, pyridium, will cause the urine to turn a reddish or orange color, and so you want to warn the patient if they have a prescription for pyridium that to look out for that, just so they're not worried when they see a orange or red urine come out. And then you want to teach them about perineal care, wiping from the front to the back, not from the back to the front, and this also helps with that. Okay, and then the last slide in this first video is the culture and sensitivity. And so here's a little computer printout here of a patient's culture and sensitivity. And you can see up here on the top, it says it's a urine culture. And then you can see right down here, it says this is the culture, and you can see that it's E. coli that's growing out. So that's the organism that caused the urinary tract infection. And then down here, these are a whole bunch of different antibiotics that they check the sensitivity for. And you can see that here there are S's which have to do with sensitivity, which means that that antibiotic will kill that microbe. And then R has to do with resistant, and that means that that bug is resistant to that different microbe or antibiotic that is given to them. And so it's very common for your patients that the doctor prescribed a certain antibiotic before we got a culture and sensitivity back. So it's good practice to check to make sure that the antibiotic that the patient's receiving isn't one of those on here that is resistant. And you could see my question down the bottom would be, should we use piperacillin for this patient? And if you go down to the bottom here, piperacillin, you can see that there's an R there, and it's greater than 256. And so that means that piperacillin, the microbe is resistant to that. And so, no, we wouldn't want to use piperacillin. And so if the doctor was giving that piperacillin, then we may want to call the doctor and say, hey, doctor, I noticed that one of these sulfa drugs up here is good. You want to switch to that. Okay, so that'll be that for this